Welcome, colleagues. Today we are diving into the 9th edition of the Neonatal Resuscitation Program, our updated clinical flight deck. Neonatal resuscitation is fundamentally about time and precision. Every baby, every breath, every second counts. Let's look at the epidemiology pyramid. 90% of newborns transition normally without intervention and require observation only. 10% require some level of assistance at birth. 5% require positive pressure ventilation. 1% require advanced interventions, including chest compressions and emergency medications. The takeaway? Most babies need observation, not aggressive intervention. However, when resuscitation is needed, execution must be flawless. Resuscitation success starts before the baby is born. Every single delivery requires readiness and a designated team leader, not just high-risk cases. First, anticipation of perinatal risk factors. Antepartum factors include multiple gestations, preterm labor, oligohydramnios, polyhydramnios, and fetal anomalies. Intrapartum factors include abnormal fetal heart rate patterns, meconium-stained fluid, operative deliveries, or a prolapsed cord. Second, the pre-birth huddle architecture. Assign a leader for every delivery. Confirm roles for airway, chest compressions, recording, and the team lead. Verify equipment, thermal controls, suction, PPV devices, advanced airway gear, and the emergency UVC tray. The 9th edition focuses on discussing the explicit cord management plan before delivery. Third, environmental control. Maintain a target temperature of 36.5 to 37.5 degrees Celsius to avoid both hypothermia and hypothermia. Preterm infants under 32 weeks require a radiant warmer, plastic wrap without drying, a hat, a thermal mattress, and heated humidified gases. Notice the immediate visual shift in the 9th edition algorithm flowchart. Initiate cord management plan is now the very first explicit step after birth. Here are the cord management guidelines. For vigorous newborns, both term and preterm, defer cord clamping for at least 60 seconds to allow continued placental transfusion. For preterm infants who are breathing or crying, defer clamping for at least 60 seconds with the resuscitation team ready at the bedside. When deferred clamping is not feasible, for non-vigorous newborns between 35 and 42 weeks, umbilical cord milking is a reasonable alternative. For non-vigorous preterms between 28 and 34 weeks, there is insufficient evidence regarding cord milking. For preterms under 28 weeks, milking is not recommended. At birth, we pull 3 rapid toggles. Is it term? Is there good tone? Is the baby breathing or crying? Path A. If the answer is yes to all, proceed to routine care. This includes delayed cord clamping for at least 60 seconds, skin-to-skin contact, thermal maintenance, and ongoing observation. Path B. If the answer is no to any, move immediately to the initial steps under the radiant warmer. These steps must happen within the golden minute. 1. Warm and maintain temperature. 2. Position the airway in the sniffing position. 3. Clear secretions only if needed using a bulb syringe or suction catheter set at 80 to 100 millimeters of mercury. 4. Dry the baby. 5. Stimulate. And 6. Attach a pulse oximeter or ECG if resuscitation is required. Heart rate is the ultimate dial and single best indicator of successful resuscitation. If the baby is apneic, gasping, or has a heart rate less than 100 beats per minute, initiate positive pressure ventilation immediately. Our monitoring hierarchy is preferred, ECG for speed and accuracy, secondary, pulse oximeter, tertiary, stethoscope auscultation. Never use palpation alone. Regarding oxygen saturation targeting updates, the starting FiO2 for babies 35 weeks and above is 21% room air. For 32 to 34 weeks, start at 21 to 30%. For those under 32 weeks, start at 30% or higher. The 9th edition shift in the Productal SpO2 target table now establishes baselines starting at 2 minutes to reflect realistic sensor placement. At 2 minutes, the target is 65 to 70%. At 3 minutes, 70 to 75%. At 4 minutes, 75 to 80%. At 5 minutes, 80 to 85%. And by 10 minutes, 85 to 95%. For PPV settings, the initial PIP for babies 32 weeks and older has increased to 25 centimeters of water. For those under 32 weeks, use 20 to 25. PEP should be 5 centimeters of water, and the ventilation rate is 30 to 60 breaths per minute. If positive pressure ventilation does not result in chest movement, you must troubleshoot using MR SOPA. In the 9th edition, MR SOPA is applied flexibly based on the clinical picture rather than strictly sequentially. M is for mask adjustment. R is for repositioning the head. Give 5 breaths and check chest movement. S is for suctioning the mouth and nose. O is for opening the mouth. Give 5 breaths and check movement. P is for pressure increase in increments of 5 centimeters of water, up to a maximum of 30 for preterm and 40 for term babies. Give 5 breaths and check. Finally, A is for an alternative airway, such as a supraglottic airway or endotracheal tube. Regarding devices, the T-piece resuscitator remains the gold standard. The supraglottic airway, or LMA, is now elevated to primary alternative status, indicated for infants 34 weeks and above or 1,500 grams and above when intubation is unsuccessful. A new 2.0 mm internal diameter ETT is introduced specifically for micropreemies under 800 grams or 25 weeks to prevent mucosal trauma. For endotracheal tube sizing and depth, the legacy 789 rule is retired. Insertion depth is now measured at the maxillary gum line. As a crucial safety rule, always confirm tracheal placement with CO2 detection. If an intubated patient suddenly deteriorates, use the DOP mnemonic: displaced tube, obstructed tube, pneumothorax, or equipment failure. Here is the sizing guide. For babies under 800 grams, use a 2.5 or 2.0 mm tube at a depth of 5.5 centimeters. For 800 to 1200 grams, a 2.5 mm tube at 6 centimeters. For 1200 to 2200 grams, a 3.0 mm tube at 7 centimeters. And for those over 2200 grams, a 3.5 mm tube at 8 to 9 centimeters. Moving to cardiovascular support. The hard stop. Never begin chest compressions without guaranteeing 30 seconds of effective positive pressure ventilation that moves the chest through an advanced airway on 100% oxygen. The trigger for compressions is a heart rate below 60 beats per minute after 30 seconds of effective PPV. Use the 2-thumb encircling hands technique over the lower third of the sternum. Compress to a depth of 1/3 of the chest diameter. Use a 3-to-1 coordination, 90 compressions and 30 breaths, totaling 120 events per minute. The cadence is 1 and 2 and 3 and breathe. Increase FiO2 to 100% and reassess every 60 seconds. For vascular access, an emergency umbilical venous catheter is primary, with intraosseous needle as secondary. Epinephrine 1 to 10,000 is indicated if the heart rate stays below 60 after 60 seconds of quality CPR. The IV or IO dose is 0.02 milligrams per kilo, followed by a 3 ml normal saline flush every 3 to 5 minutes. Volume expansion with normal saline or a negative blood at 10 ml per kilo is indicated for history of blood loss or persistent shock. Special situations require key deviations. For Robin sequence, position prone or lateral and use an oral or nasopharyngeal airway. For choanal atresia, insert an oral airway. For congenital diaphragmatic hernia, intubate immediately. Never use bag mask ventilation or CPAP, and place an OG tube to decompress the stomach. For gastroschisis, use a sterile bowel bag. For myelomeningocele, position prone and use strictly latex-free equipment. If there are maternal opioids, support with PPV but do not give naloxone. In post-resuscitation care, maintain normothermia between 36.5 and 37.5 degrees. Candidates for therapeutic hypothermia must initiate cooling within 6 hours of birth. Finally, cessation of resuscitation may be considered if there is no detectable heart rate after 20 minutes of continuous, high-quality resuscitation. To summarize the key changes from the 8th to the 9th edition, the algorithm now explicitly starts with initiating the cord management plan. Cord clamping is now deferred for at least 60 seconds for most newborns. The SpO2 target table now starts at 2 minutes rather than 1 minute. Initial PIP for term babies has increased to 25 centimeters of water. MR SOPA is now flexible in its order, and the supraglottic airway is elevated to primary status. ETT depth is measured at the gum line instead of the lip. And we now have a 2.0 mm tube option for micropreemies. By following these updated clinical flight deck directives, we ensure that for every baby, every breath, and every second, we are providing the best possible care. Thank you.